education and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Right, a very good morning, good afternoon, and good evening, ladies and gents. I'm Vikas Khanduja, consultant orthopedic surgeon in Cambridge, UK, and one of the founders of SICOT Pioneer, and currently the president of SICOT as well. And it's an absolute pleasure to welcome all of you logging in to this webinar from all around the world. Now, SICOT Pioneer was born during COVID as a fairly small platform, but has grown enormously as you've seen over the years. We've embraced a digital future for SICOT. And through this platform, we've done over 95 events and have had over 120,000 views from over 110 countries around the world. So big thank you for joining us and following us as well. Now, today's webinar is quite special because of two reasons. It's the first one that we're collaborating with the Chinese Orthopaedic Elite Club. And it's also the first one which is actually being translated using AI into Mandarin throughout. So big thank you and ever so grateful to the PEDS committee chair, Prof. Alaric Aroojis, who's managed to get this going, Professor Zhang from China, and Professor Jie Wen as well for actually collaborating with us to produce this webinar. And to the stellar faculty who've given up their precious time, and I will let Al introduce all of them to you in a minute. We'll try and make this webinar as interactive as possible for you. So please do post in your questions. And if for any reason you can't join us today, then please do access it on our on-demand platform. Once again, a big thank you and hope you enjoy the webinar. Over to you, Al. Thank you.
Thank you, Vikas, for that very kind introduction. My name is Alaric Aroojis. I'm a pediatric orthopedic surgeon from Mumbai, India, and I'm the current chair of the SICOT Pediatrics Committee. As Vikas mentioned, this is the first time we are collaborating with the Chinese Orthopaedic Elite Club, and we're really looking forward to this wonderful collaboration going forward. Along with my co-moderators, Dr. Jie and Dr. Qiang, we are really looking forward to a wonderful experience today. We have set up a whole set of wonderful cases and talks, and I'm sure that all of us are going to benefit from this learning experience. The two conveners of this webinar are Dr. Jie Wen from China and Dr. Saleh Al Saifi from Kuwait. And I will hand it over to them to introduce our moderators and our speakers for today. Thank you very much and wish you all a wonderful learning experience. Over to you, Jie.
Hello, everyone. I'm Dr. Zhongli Zhang from China, from Tianjin, and also a pediatric orthopedic surgeon. And now I'm serving as chairman of COEC Pediatric Orthopedics. It's my great privilege to warmly welcome you to today's webinar. This collaborative event brings together a globally community of experts and to share knowledge, discuss innovations, and to address the pediatric orthopedic care. COEC and SICOT share the same dedication and passion for improving patient outcomes and enhancing orthopedic research. We are hopefully that we can elevate the standard of orthopedic care and make a lasting impact on the global orthopedic community. Thank you and enjoy the webinar tonight. Thank you.
Thank you, Dr. Zhang. So I think we'll be starting the first session. If you don't mind, I'll be introducing Dr. Sattar Alshryda. He is a consultant trauma and pediatric orthopedic surgeon, and he's the chair of education committee and a member of academic committee as well at the Al Jalila Hospital in Dubai, United Arab Emirates. He will be speaking to us about the measurement of normal range and application of the alignment of the lower limbs in children. Here you go, Dr. Sattar, please go ahead. Thank you very much for joining us.
He may be muted, I think.
Dr. Sattar, I think you should probably unmute yourself.
Sorry, my apology, guys. Can you hear me now? The title of the talk is the measurement, normal range, and application of alignment of the lower limb in children. Next slide, please. The objective of this talk is to understand deformity, understand terminology, and plan how to correct deformity and what are the challenges in children. Next slide, please. There are a few resources that can be useful for all people from different levels, from junior to senior. This is one beautiful book, The Art of Limb Alignment. Next slide. Another more heavy book, but very useful as well, Dora Bailey book about principle of deformity correction. Next slide, please. And my favorite, of course, is the Pediatric Lower Limb Deformity by Sanjeev, who's one of the moderator here. Next slide, please. Also, there are a few good courses around the world to teach deformity. It is always useful to attend one course at least once in your lifetime. There's the UAE Deformity Correction course, there's the Baltimore Limb Deformity course, and there's the Hull Deformity course in the UK. Next slide. So the question is, what is a deformity? Next slide, please. A limb deformity can be defined as distortion from the normal form, and this may be in the form of angulation or translation or a bit of both. Next slide, please. We know there are three planes in 3 dimensions: the sagittal plane, the coronal plane, and the axial plane. So the deformity could happen in any of these planes in form angulation and translation. Next slide. There's a video now. I'm going to show a video to explain this more. So in the coronal plane, angulation goes varus or valgus. Translation could be medial translation or could be lateral translation. And it could be a bit of both. There's translation and angulation. And this could be in both directions. In the sagittal plane, angulation is procurvatum or apex anterior. Or in the other direction, recurvatum or apex posterior. Again, it could be combined. It could be a translation and angulation. Here is translation anterior and posterior. The angulation and translation in the axial view, it could be external rotation or internal rotation. But also the translation mean is the shortening or lengthening. It's better to see it from the lateral view. Next slide, please. So there are, in terminology, there are 3 important terminology we need to understand. The first of the terminology is the mechanical axis, which is a line connecting the center of proximal joint to the center of the distal joint. Next slide, please. And this could be for the whole limb, from the center of the hip to the center of the ankle. And this is the mechanical axis of the whole limb. But also there will be the mechanical axis of each segment or each bone, which goes from the center of the joint above to the center of the joint below, for the femur and for the tibia. Next slide, please. Then there's the anatomic axis, which is a line on the coronal plane, is the mid-diaphyseal line. Next slide, please. So if you have a bone, you have two diameter. You choose the middle of the top mid-diameter to the middle of the bottom mid-diameter, and you draw the line, which is this, the anatomic axis in the coronal plane. In the sagittal plane, if you put next slide, please, slightly different in the sagittal plane. It goes between two fixed points. If you, next slide, please. So for example, for the femur, it is from the center of the femoral head to a point which is third the way through the physeal scar, as you can see in this drawing. For the tibia, it is from the center of the ankle to a point on the tibial plateau, which is 1/5 anterior and 4/5 posterior, as you can see in this slide. So there's slight variation in how we define the anatomic axis in the sagittal and coronal plane. Next slide, please. Then we'll get to the joint orientation angle, which is created by the above-mentioned line with a mechanical axis or anatomic axis and the joint surface line. The nomenclature for these joints are standard. First, we mentioned the axis with its mechanical or anatomical. Then we mentioned the side with the medial or lateral. Then the side with the proximal or distal. Then the bone with its femur or tibia. To make it easier for junior to remember these, we use the acronym. If you move to the next slide, please, which is all direction toward bones. Next slide, please. Yeah. So A for the axis, D for the side, T for the site, and B for the bone. Next slide, please. And move to the next slide, please. So if you look at the mechanical axis lines and the angles from proximal to distal, as we mentioned, the nomenclature is standard. We have the mechanical lateral proximal femoral angle, which is 90 degrees, and the range is from 85 to 95. Then mechanical lateral distal femoral angle, then mechanical medial proximal tibial angle, then mechanical lateral distal tibial angle. So if you remember these angles, probably can analyze the deformity of the lower limb. They have different numbers, but if you remember the number 90, which is you're almost right about them. Next slide. Again, for the anatomic axis, they are slightly different numbers. The main difference comes from the femur, because we know the mechanical axis and the anatomical axis of the femur slightly different by around 7 degrees. I'm not going to go through the angle, but you can look in the books. Next slide. On the lateral, again, we have the same method to apply for naming these angles. You have proximal distal femoral angle, which is 83. You have proximal posterior tibial angle, which is 81. Then you have the anterior distal tibial angle, which is 80. You need to remember these numbers, unfortunately, to be able to analyze deformity. Next slide, please. So this is another look at the terminology. We need to know the axes with a mechanical anatomical, and we need to know the joint orientation angle. Next slide, please. So when I face a child with deformity, the first question I ask myself, is there a deformity worth correcting? The second question, what segment is affected? Where is the apex of the deformity? How big and in which direction the deformity? Where should the osteotomy or correction be? And what correction strategy I'll use? Next slide. In our course, we teach our trainee to use the map the APCs, which I'm going to go through with you step by step. Next slide, please. M is for the mechanical axis deviation. We need to find the mechanical axis deviation. Next slide, please. A for analyze the angles. Next slide. P to pick the bone. Which bone is deformed? Next slide, please. A, the apex of the deformity. Find where the apex of the deformity. Next slide, please. Find where you're going to put your bony cut. Next slide, please. And see what's your correction strategy. Let's take an example. Next slide, please. Here we have a deformed bone, but we need to analyze it. Next slide, please. So we draw the mechanical axis, and for the mechanical axis, center of the hip to the center of the ankle, we can see the mechanical axis doesn't go into the center of the knee, so we have some deformity. Next slide, please. Then we need to analyze the angles. Next slide, please. So we draw our joint orientation angles. Next slide, please. Then we draw the mechanical axis for each segment, and we can see we have lateral distal femoral angle of 94, which is above normal. You remember the number 90, this is above 90, or it's practically 87. So we have 7 degrees from here. And also we have the proximal tibia 76, which again, around 10, 11 degrees below normal. So next slide, please. So if we're going to pick the bone, we have 2 bones here. Next slide, please. So we have both deformity in the tibia and the femur. Okay, then let's focus on the tibia for the sake of simplicity. We draw the mechanical axis or the joint orientation line of the proximal, the normal one on the proximal. Next slide. Then we draw on the distal as well. Next slide, please. And we can see they intersect in the proximal part of the tibia where the deformity is. Next slide, please. So our angle is here. Next slide, please. And this is the bisector line. This helps us to predict what's going to happen with the deformity when we correct it. So if we do our pony cut, next slide, please. If we put our pony cut in the center of where the deformity is, we can correct this deformity. So our osteotomy will be there. But the question is that, is it the right place for osteotomy, given in mind where the nearby structures, where the growth plate is, what kind of fixation you do? This varies between different deformities. Next slide, please. Then your correction strategy, you have to decide, are you going to use a frame to do gradual correction? Are you going to use a blade or a nail to do acute correction? Next slide, please. So this is in summary. Is there a deformity worth correcting? What segment is affected? Where the apex of the deformity? How big the deformity and which direction? Where should the osteotomy and correction go? And what correction strategy be used? If you remember these steps, usually can handle most deformities. Next slide, please. And the map, the ABC, will make it easier to remember these steps. Next slide, please. So now we understood deformity, we understood the terminology that used for it, and we know how to plan to correct these deformity in the simplest way. So what are the challenges in children? Next slide, please. There are many challenges in children. First, the presence of a growth plate. Next slide, please. The presence of a growth plate can affect the selection of osteotomy. If it is too close to the growth plate, you might have difficulty in choosing the right place to do your osteotomy, and also it affects the type of fixation. Also, it influences the deformity itself, particularly if there's leg length differences, because to growing children, this deformity should change with time. Next slide, please. Most of the deformity change with time in a linear manner, as Shapiro shows. So the deformity now is small. As the children grow older, the deformity will expect to increase. But that's not always the case, depending on what the cause of the deformity. Next slide, please. Also, the growth plate is not always a bad thing, because sometimes you can use the growth plate in the simplest form of guided growth to correct deformity. Next slide, please. The second challenge is remodeling. Next slide, please. You can see this deformity almost corrected fully over a year and a half. Okay, next slide, please. I mentioned earlier we have 3 standard plane to consider when we correct deformity. However, in children, we have 4 standard plane. Next slide, please. The 4th standard is, or the 4th plane is time. Deformity change between now, next year, and the 2 years' time. So always think about in children, there are four planes. Next slide, please. Also in children, we have normal variants. We have, in the first 2 years of life, we usually have gena varum, which correct naturally. Then we have gena valgum, which again correct naturally. These children have femoral torsion and tibial torsion, which you need to think about how they evolve in children before you consider correcting them. Next slide, please. And children also exhibit some unusual phenomena, like Cousin fracture. We know proximal tibial fracture, not very often, but sometimes they do in valgus deformity because of the overgrowth of the medial side. We always, when I was junior, always read about these things, and they say they correct over 18 months. But the reality, not all of them do. Some of them, they really get worse even after 18 months, and they need correction. Next slide, please. This one of my patients, I waited 18 months, 2 years, 2.5 years. It was getting worse and worse. So my hand was tight. I corrected surgically. Next slide, please. And incomplete ossification. And this because of the lack of the or the smaller size of the epiphyses of the bone, it was difficult to measure these angles. And sometimes because they are made of cartilage, they accentuate deformities when they weight bearing. Next slide, please. So sometimes we rely on MRI scan to show us these measurements well, or in theater arthrogram. Next slide, please. The challenges when you consider deformity correction in children, really the clinical assessment and rehabilitation for these children, they are not as cooperative as adults. So this will add on the challenges. These are some references. And I hope you find the presentation useful. Thank you very much.
Thank you. So the next speaker, we have Dr. Chenghe Qin. Chenghe Qin is Dr. Professor Qin is now the chairman of the Limb and Reconstruction Department of Orthopedic Branch of China International Exchange and the Promotive Association of Medical Health and Healthcare. And also is the vice chairman of the Children's Trauma and Limb Reconstruction Society of SICOT China, and there are also some other national academic committee. So it's a big privilege and honor to introduce Professor Chenghe Qin to give us the next talk. He'll talk about the deformity correction strategy, CORA selection, and options. Please, Dr. Qin.
Good morning, good afternoon, good evening. Thank you very much for asking me to speak on deformity correction strategy, and I will try and explain some basic principles that we use when we are planning deformity correction. So first of all, we have to identify the deformity and then identify which bone the deformity lies in. Then you have to decide whether it needs to be correct or not, because not all deformity require correction. Once you have decided that you want to correct of deformity, then you need to decide where to make your osteotomy to correct and how to stabilize. So the map and ABC Mr. Sattar referred is a very, very, very good algorithm to planning correction deformity. When evaluating no-name alignment, it's imperative to consider the name as an integrated unit rather than a single bone. The mechanical axis is a line joined from the center of the hip to center of the ankle. Next, please. The mechanical axis is a line joined from the center of the hip to center of the ankle joint in patient who is standing where X-ray beam is centered between the knees, and in normal, the line would through the center of or slightly medial in the center of the knee joint. So the distinguish between the anatomic and the mechanical axis. Next, please. Next, please. So first of all, you identify that deformity, you have to look at the mechanical axis of the no-name. So for example, you can see the joint mechanical axis on the picture. We show that this mechanical axis is deviate. The right side, the picture is abnormal, is a gene virus. So next, please. Next, please. So following, draw up the mechanical axis. The next step is to analyze the joint angles. So the joint of the hip, the knee, the ankle all have a range of normal angles. And you can see those angles in this picture. And so you need to know what is normal joint angle before you can identify whether they are abnormal, because if they are abnormal, maybe the deformity around of the joint. So for example, in the no-name, we tend to use, around the knee joint, we tend to use the natural distal femur angle and the medial proximal tibial angle for the deformity around the knee joint. Please next. So now we are going to think about the technical aspect of correcting the deformity. So the first thing to think about the A mentioned by Dr. Sattar. which is the apex of the deformity. And by that, we means the point around which the deformity has occurred. So we talk about the apex of the deformity. And the limb reconstruction, we usually see CORA. CORA means the center of the rotation of angulation, and it is the center around which is you correct the deformity. It will return to its anatomic position. For example, please next. Next. So, for example, if you look at this, the middle picture, you will see that this is a fracture that is here, but here with some translation and angulation deformity. So when it is here with translation, there are some things that looks as though it may be the apex of the deformity, which is here, which is the obvious apex. However, because the fracture has here with the translation, the true apex of the deformity is not where the obvious bump is somewhere different place. And if you were to draw the diaphyseal line of the distal fragment and the proximal segment, the intersect point, the place, and this is different as the obvious bump. So this is the true. This is the true apex. So this is the CORA. Next, please. So the bisect line passes through the CORA and divides the angle between proximal and the distal axis, so as the optimal path for correction, also referred as a correction line. So a line is osteotomy along this bisect to ensure angular correction without introducing translation. Please, next. So now if we, next please. Now if we move on to where we are going to make our cuts, which is the level of the osteotomy, there are 3 rules that we need to consider. If you create osteotomy at the level of the CORA or ARCA, that is known as osteotomy rule 1. So you are going to correct your deformity at the CORA or ARCA itself. And as far as possible, we will try to do this because with realignment and also without the translation. Osteotomy rule 2, what that means is that you perform your osteotomy in a different place from the CORA. But when you do correction, you are still move the bone around the CORA. You will end up with a secondary translation. But osteotomy rule 3 is where the bony cut and the CORA are not related at all. So you make your bony cut at a different place from the CORA, and you also do your correction at a different place from the CORA. And that you will give you no correction. It will give you a secondary deformity. So this is an iatrogenic problem, and we should try to avoid it. Please, next. Now, next, please. So now you look at the picture, you will see that this is a CORA of deformity, which this is the intersection of the axis of the proximal and the distal segment. Now, if you perform open wedge, as you see here, then you will create length. If you do a next, please. Next, please. If you do a hemi wedge, as you see here, then you will create. If you do a hemi wedge, which is to see that you take a small wedge out of half of bone, and you open up the other half of the bone, it's known as a hemi wedge. So will give you no increase or decrease the length. And you next, please. If you would perform a closed wedge osteotomy, then that will shorten the bone. So depending upon whether the patient is long or short, or what you are trying to achieve, you can't do either of these 3 cuts. Please, next. Sometimes maybe we do dermal osteotomy, especially periarticular deformity. So a closed wedge, so dermal osteotomy are employed when the osteotomy can't pass through both the CORA and ARCA. It's similar rule 2. Is when you restore the alignment may be secondary introduced to the translation. Please, next. This is a translation deformity. Maybe you need two wedge osteotomy of equal magnitude in opposite direction at the level of the respective CORA. Next, please. So this is a young lady. We draw the mechanical axis bilateral. So the left and right mechanical axis deviation, natural deviation. Next. We should identify the deformity, the valgus deformity. We should also identify the exact position, the deformity. So we draw the femoral mechanical axis and the tibial mechanical axis. Next, please. The next, we should measure the ankle joint, especially when we use the knee deformity. So we usually tend to use the natural distal femoral angle and medial proximal tibial angle. So we measure the lateral distal femoral angle. It's normal, bilateral. So next. So extend the femur, the normal mechanical axis is standard for the normal proximal tibial mechanical axis. Next, please. So we draw the distal tibial mechanical axis. We intersection here, intersection here. This is a CORA, and we draw the bisect. Next, please. So we cut the bone at the CORA and around the arca, correct the bone. So this is a rule 1. So realignment and without translation. Please, next. This is a young lady. So left leg short and valgus deformity. We also draw the mechanical axis. This is a natural deviation. Please, next. We draw the mechanical axis of the femur. We draw the natural distal femoral angle. So the CORA is close, very close to the knee. Next, please. We can't cut the bone at the arca or under the CORA. So cut the bone, proximal the CORA, and correct the bone around the arca. But so realignment the mechanical axis, but also secondary introduce the translation. Those are the rule 2. Next, please. So the intro operation, so how to correct it, how to cut it, where we cut it, how to stabilize, how to correct gradually or acute. So like this case, next, please. Next, please. So we take a plate and put the pin, half pin, and use the mononatural external fixation, correct and stabilize the bone and lengthening the bone. Next, please. So we put the half pin perpendicular to respective the bone, the segment, perpendicular distal segment, the anatomical axis, and percutaneous cut the bone. Please, next. We just 2 centimeter cut. Then correct the bone. So just make the 2 part of the half pin parallel and put the rear, fix it. So correct the valgus deformity. And this is the rule 2. So realignment the mechanical axis and also introduce secondary translation is rule 2. Next, please. So operation, after operation, just 30 centimeter, 30 minutes and 2 centimeter incision. Next. 1 day post-operation weight bearing, 1 week lengthening. So realignment and also restore the equal length. Next, please. 4 months, 5 months, remove the external fixate. Next, please. Next, please. This is a young boy. The parents complain the left leg short, but we draw the mechanical axis. It's normal. So the normal alignment not just equal the mechanical axis and also the normal joint orientation. We measure the joint orientation. So the distal femur varus and proxitibial valgus. So this is a balanced deformity. So even this the two sides of the deformity, but the mechanical axis almost normal. Next, please. So we should next, please. So we should correct this femur, also correct the proxitibia. Next, please. Next slide, please. Next. Next slide, please.
Dr. Jie Wen, is anything?
Anything problem?
I think we have lost the projection. So whoever's projecting the slides, can someone project that, please? Jie Wen, are you projecting it from your laptop?
So yes, this is almost finished. So for appropriate patient, the exact reconstruction surgery should be performed. Each patient is different, and a careful assessment is needed to restore the normal alignment. Oh yes. Not just correct the distal femur and also proximal tibia, correct the angulation deformity, and also 1 week post-operation with lengthening, with restoration of the alignment, also restoration of the equal length. Next, please. So for appropriate patient, the exact reconstructive surgery should be performed. Each patient is different, and a careful assessment is needed to restore the normal alignment, include the normal mechanic, the axis, the normal joint orientation, and the equal length. Meticulous assessment and measurement are required. A perfect pre-operation plan is a key to success. Thank you very much.
Thank you, Dr. Qin. So we will proceed to discussion or next section.
Yes, so we'll move to the next, which is the case discussion. And we've got 4 very interesting cases that have been lined up by our speakers, 2 from SICOT and 2 from COEC. So our next speaker who's going to present the first case is Saleh Al Saifi, and he's going to speak on the case on the angular deformity of the lower limb caused by an epiphyseal injury treated by growth modulation.
Thank you, Alaric. Good evening, everyone. I'm just trying to present this quick case that I had actually encountered about 8 years ago. So I'm presenting next, please. So this is a 1-year-old guy or boy who was actually had an intraosseous cannula or venous access, which actually complicated by proximal tibial infection. So he presented to the clinic with this following gait and the deformity, as you can see probably on the next video, please. Next. So the child was walking with a genovarm deformity, internal rotation of the tibia, a limping gait, and also a procurvatum deformity. So this is how he appeared to my clinic just after walking. And at this point, we started to investigate the case, and I had to send him for x-rays. Next, please. So on the next slide, his proximal tibial epiphysis is completely gone due to the infection. So from this point, I have told the father that, we have just to monitor this and see where is the epiphysis will take us in the future, because this is something that we cannot predict at this point because he was very young. Next slide, please. So this was at 2016. At 2017, you can probably see that his proximal tibial physis is still not appearing, and he's going into keeping up with the same deformity. At this point, the father has disappeared for about 2 years, and he seeks another opinion into a different country. So he went abroad. Next slide, please. And he actually met a surgeon who was a bit aggressive. And that surgeon, at this point, he did not respect the deformity very well, and he went ahead and did a proximal tibial osteotomy. And that osteotomy was actually directly, specifically the procurvatum. So he actually, at this point, he addressed mainly the procurvatum, and he turned the deformity into a recurvatum deformity. Can you go next, please? So this is how he looked the year after surgery. So he still have this genovarus deformity, or probably tibial vara, femur valga distally, and a very severe extended deformity or a recurvatum deformity. And at that point, I told the father that, the best probably treatment at this point is just to use a circular frame, because you can address everything at one point at this age, which is almost around 4 years and a half at that point. Next, please. So this was probably my plan, how to work ahead with it. Next, please. And the father is still not willing to do the surgery. So again, he kept waiting and waiting. So next, please. If you can play the CT. So this is the CT films and cuts that shows the proximal physeal or the physis of the tibia with the complete destruction. And at this point, the father was agreeing on doing an epiphyseodesis to address the proximal lateral aspect of the tibia, just to correct the varus of the tibia. Can you go to the next slide, please? And this is how his MRI looks like. So probably I wasn't really convincing, because the father was trying to stay away from surgeries. And after a lot of convincing, I told him that, we probably have to put on an AT-plate just to see how much we can correct in this deformity. I know it's not going to correct everything, but we wanted to do, at least a trial. Next, please. So an AT-plate was placed on the proximal lateral part of the tibia. It managed to correct a bit of the deformity. Next slide, please. And it corrected a bit. The recurvatum probably was spontaneously correcting. The varus is still there. And then before moving to the next slide, he was advised by another surgeon that, the best modality of treatment here is to do a high tibial osteotomy. And I told him, no, if the AT-plate is not working, I will still go with a proximal frame. So should we allow discussion here, Alaric? Or should we just move ahead?
I think we'll complete the case, and then we'll take some questions at the end of the case.
Okay, sure. So at this point, his proximal AT-plate did not work. If you move to the next slide. And he went on to another surgeon where a high tibial, one single cut, like oblique osteotomy with a reverse oblique, I would call it, to the proximal tibia was done. So this was in 2023. Next slide, please. And you can see it's slightly adjusted in terms of the procurvatum or the recurvatum. The procurvatum is back to almost normality now on the sagittal axis. The coronal axis is still deformed, but the proximal femur, the distal femur, is actually causing deformity. The tibia has a big dent on it, on the proximal epiphysis. And can you go next slide, please? So this is him after healing. And we have a clinical, this is 25. And can you go to the next slide, please? And this is him clinically now. You can see the video. So he started with a genovarum procurvatum internal rotation. He has now leg length discrepancy, genovalgus of the femur, genovarus of the tibia, and a recurvatum of the tibia. So this is how he looks like at this point. I have my plan in head. I know that he's actually around this time he's 9 years old, and I think he's a good candidate for surgical intervention that we will be discussing after these slides. And that's all of my case, and things are open to discussion. So my conclusion is the guided growth is actually a valid option to treat angular deformity, not in this specific case. So that's why we have to choose the right time and the proper pathology as a key factor for the treatment. And there is also always an alternative method in combination with AT-plate or growth modulation that should be used, and the family discussion prior to any epiphyseal is mandatory, just in case that the correction doesn't work well or is not expected. Thank you very much.
Thank you very much, Saleh. That was a really interesting, very challenging case. I think we'll allow one suggestion from the panel. So there's anyone on the panel, either from SICOT or from COEC, who would like to comment on this case and especially recommend moving forward, what would they recommend now for this particular case? Is there anyone? Feel free to speak right now.
Well, yeah, I agree with Al. It was a challenging case, and I'm not sure if guided growth is totally off. First thing is it's a sick physis. So there's two pieces of information that you may or may not have had. One is, how does the joint actually look like? So either an arthrogram or another MRI would help with figuring out how much of the cartilage is deformed. And then you could remeasure your joint orientation angles based on that. And and I think if there is asymmetric growth, it may be best to just shut the rest of the growth plate, including the fibula, so that you wherever you are, you hold that pattern, and then, like you said, address deformity and length with an osteotomy, anticipating future growth. I mean, he's still growing, but I think despite all the surgeries, he's functionally doing okay. But I agree with your plan of a hexapod, and then perhaps closing the rest of the physes of the left proximal tibia and fibula.
Thank you. Thanks, Sanjeev. Yeah, that was a great suggestions. We'll move ahead to the next case, and maybe Saleh, you could introduce our next speaker.
So I'd like to introduce my colleague, Dr. Jie Wen. He's our colleague from China. He's actually my partner in moderating this. He's a member of the Recon group and Chenghe Orthopaedic groups of the Orthopaedic branch. He's a SICOT member as well as the China Orthopaedic Elite Club Pediatric Committee. He will be talking to us today about the angular deformity of the lower limb caused by the epiphyseal injury treated with osteotomy. Dr. Jie, please go ahead. Thank you very much.
Thank you. Today I want to share a case with the title of angular deformity of lower limb in children, and it's a case of ankle varus after McFarland fracture. I'm Dr. Jie Wen from Hunan Provincial People's Hospital in China. Okay, here's the case. It's a boy with 13 years old, and when he comes to our department, the appearance is like this. So it's a right ankle varus deformity 3 years after McFarland fracture. Here is the X-ray of this patient. We can see when he come to our hospital, it's 2018 and in the June, and the X-ray shows the LDTA in the AP view it's 16 and the ADTA is 80 degrees. And our diagnosis is right ankle varus deformity. And then we give in a 3D CT. And the CT shows that there is angular deformity in fibula and the distal end of the tibia. And there is a typical epiphyseal bar. And we go dig the past the history of this patient. This is the 3 years ago when he was first injured. And the X-ray is from 2015. And we can see from the X-rays, here is a very typical McFarland fracture, and it's a Soto Harris type 3 injuries. From this X-ray, we also measured the LDTA, it's 90 degrees, and the ADTA is also 90 degrees. And he is treated by another hospital, and they gave him a cast for 6 weeks. And after 2 years later, 2 months later, and the patient received the first surgery in another hospital in 2015 November. We can see from the X-rays and using a plate in the fibula and using a plate in the tibia. and then with some screws and some K-wires from the X-ray, we can see the LDTA is 91 degree and the ADTA is 80 degrees. And 1 month later, the patient received the second surgery, and it was distal screw removed. And from the X-ray, we see the LTA and the ADTA is normal. And 2 years later, the patient received the third surgery with a total internal fixation removal in 2017. And the patient then is 12 years old. And after the internal fixation removed, we can see the X-rays, the LDTA is 88 degree and the ADTA is 83 degrees. And there is a bony defect of the distal end of the tibia. And then in 2018, the patient comes to our department, and the appearance is a right ankle varus deformity. And this is the X-rays from the beginning. So the treatment plan, we give this patient a 30-degree osteotomy above the ankle joint and the epiphyseal arrest and the pins to fix the ankle joint. And then we use a Elizarov external fixation to lengthening the tibia and the fibula for 3.2 centimeters. This is an intra operation pictures, and we're using the guide pin to moderate the osteotomy directions, and we do the osteotomies. And when after that, we're using a KOS to fix the ankles. And then this is the fourth surgery and the first surgery in our department. And the patient is 30 years old, and this is the post-operation X-rays, shows the LDTA is 88 degree and the ADTA is 80 degrees. And then we did the lengthening, and 4 months after the fourth surgery, you can see from the X-rays the tibia and the fibula was lengthening for and the after the lengthening reached 3.2 centimeters, and we removed the external fixation. And from this, you can see the osteotomy site has a bone healing, and then we give him a cast for 1 month, and the patient was 40 years old. And this is the fifth surgery for the external fixation remove. And there is a dramatic things happen when we take off the cast, and when the patient was 60 years old, 2 years after the surgeries, when the kid was playing basketball, and he injured from the playground and come to our hospital again, and we gave X-rays, and there is a tibia and a fibula fracture for the patient, and the parents of the patients refuse cast. So we give in an external fixation again. This is the 6th surgeries, and from this, after we get a bone healing, we give him a cast for 2 weeks. And when he came back for the next surgery, we removed the external fixation, and from 2021 to 2024, the patient grows from 60 years old to 90 years old, and we give him an X-ray of the whole lower limb, and we can see there is a slightly discrepancy for 0.6 centimeters, and the appearance from 2018 to 2021 and 2024. You can see these 30 years old to 60 years old to 90 years old. So it say 9 years for 7 surgeries. But for good luck, we have a very good appearance. So here is the discussion. For the delayed and the displaced, the McFarlane fracture, what can we do? So anybody want to join the
Great.
discussion?
Thank you, Jie Wen. I think you've really shared a very interesting case with us. Distal tibial fractures and growth arrests are really very challenging to manage, and you've shown us really nicely over the years how you managed this patient. And you had a little twist in the tail at the end when he developed a tibial fracture after a football injury. So, as Sanjeev Sabharwal always says, it's not over until it's over. So, when you monitor these growth arrests, you really have to follow them up for quite some time till you are sure that everything looks good. But I think you managed the case really well. And thank you very much for sharing with us. In the interest of time, we'll move ahead to the next speaker, and that's going to be my friend Sanjeev Sabharwal. So maybe Saleh, could you introduce Dr. Sanjeev Sabharwal?
Sure. So if you allow me, I'll introduce Professor Sanjeev Sabharwal, if I pronounce it very well, Dr. Sanjeev. He's a pediatric orthopedic surgeon who treats children and young adults with a wide range of musculoskeletal problems. He's a professor of orthopedics at the University of California, San Francisco, and he's an expert in surgical limb reconstruction. Dr. Sabharwal directs the Limb Reconstruction and Lengthening and Complex Reconstruction Center at the University of California in San Francisco at the BNUF Children's Hospital. Dr. Sanjeev.
Great. Thank you. Thank you, Saleh. Yeah, and I know we're a little bit behind, so I'll just sort of move along with this case. So we're switching themes and we're talking about developmental growth issues in children. So we'll present a case of angular deformities where it was really, I treated this patient all the way along. So, but I learned a few lessons around. So let's go to the next one, please. So this is a 7-year-old who I saw with early onset Blount's, varus deformity bilaterally, right worse than left, with some limb shortening on the right side, which was the more severe side. And I performed gradual correction with some realignment on the right side with a proximal tibial osteotomy and a guided growth on the left. And so you could look at the dates at the bottom. He had a quick recurrence on the right side, and perhaps I did not adequately correct the right side. But he was lost to follow up. Next slide, please. And so here he is 2 years later, comes with a windswept deformity with worsening on the right side and overcorrection of extreme valgus on the left with a broken metaphyseal screw at the guided growth plate. So, like Al said, it's not over till it's over. So he's still growing. At this point, he's more mature. He's probably 9 or 10 years old at this point. And next one, please. So we decided to do a plateau elevation the best I could on the right and remove the hardware, most of it on the left side. And let's just move on in terms of the timing here. So that's December 2011. He's got joint obliquity. And as one of the speakers earlier said, there is malalignment and malorientation. So this is a little bit of a struggle on the right side. Do you accept a little bit of varus malalignment, or do you correct the malalignment and give him a little iatrogenic malorientation? So I chose to do the latter. And next one, please. So we put a guided growth on the right distal femur. You can see it's created a little bit of joint obliquity on the right knee, but his mechanical axis has been restored on the right in that middle slide. And on the left, it's interesting, it went from varus to extreme valgus, and now on your right slide, he's back to extreme varus despite putting a guided growth plate. So I think the physeal sort of sickness worsened over time as he got older. So here we are, October 2014. So what do you do now? And so he's advanced in his Langenschkoll staging as well. Next slide, please. So on the left, then we went ahead and did completed the proximal tibial epiphyseodesis. I think scraped the proximal fibular physis as well, and then did a plateau elevation with restoring his joint orientation with a structural allograft. And next one, please. So here he is at skeletal maturity after a lot of surgeries. He's got a reasonable limb alignment and restored mechanical access for the most part. So next slide. I don't think we have time to sort of go over the details, but just in terms of what are the risk factors for recurrence after realignment osteotomies for early onset Blount's. I think there is limited data, although there are multiple studies. I think most are case series. And what comes through most of these studies is that osteotomy realignment at an older age, beyond age 4 to 5, with advanced Langenschkoll staging and obese kids, and if you leave a little residual varus, all those are factors that are additive in terms of recurrent deformities. Now, it's interesting, these same rules don't all apply if you do guided growth for early onset Blount's, but maybe that's for another day. Next one, please. Yeah. And now the trend is to also categorize the medial physeal slope. And there's 3 ways to do it. There is the Lamont classification, which is more categorical, A, B, and C, based on the shape of the medial metaphyseal slope. And the other 2 variables, which are continuous variables, such as the metaphyseal physeal slope angle, as well as the medial metaphyseal beak angle. And there are thresholds for the metaphyseal physeal slope. I think people say more than 60 to 70 degrees is a worse prognosis. And in the study from Thailand, it appeared that medial metaphyseal beak angle of more than 128 degrees was a bad prognosticator. Next one. And so this is sort of the take home as far as indications for a plateau elevation, advanced Langenschkoll stage, child older than 6. And there are different techniques and different methodologies in terms of elevating the plateau, but should always remember to combine it with the lateral hemiepiphyseodesis of the tibia and the proximal fibula so as to avoid recurrence. And this operation will not address a limb length discrepancy unless you do a concomitant or stage lengthening. And I think final couple of slides. Next, please. Yeah, and we're starting to use this imaging with MRI called diffusion tensor imaging in Blount's as well. But the jury's still out in terms of how it helps. But this is a functional way of looking at physeal health. And this was a patient of Blount's that I recently did. And I did a guided growth despite not having much activity biologically medially. And time will tell how that pans out. Next, please. And so again, the take home is, just like you've heard in earlier talks, you got to do a comprehensive analysis, not just radiographically, but also clinically and psychosocially, address all deformities, individualized treatment with guided growth and/or osteotomies, and in general, strive for a knee joint obliquity of 5 degrees or less to avoid shear forces across the knee joint. Again, avoid iatrogenic deformities such as translational, and need close follow-up to skeletal maturity. And finally, I would like to invite you to our SICOT endorsed, next slide, webinar, where some of you are participating as well. And we'll do some detailed case discussions on post-traumatic deformities. And it'll be a very global faculty. So please join us for that. Thank you.
Thank you, Sanjeev. That was a wonderful case. Dr. Qiang, any comments you have to make?
No, that's so far. Thank you.
So we'll move on to our last speaker, and that is Dr. Qingda Lu. And I'll ask Jie Wen to introduce him as well.
So next speaker is also from COEC is Dr. Qingda Lu. He's from Shanxi province, China. He's the head of a spinal deformity and trauma specialist group, and also a member of SICOT China. So he will talk about the angular deformity of lower limb caused by rare disease. Please, Dr. Lu.
Yeah.
Yes. Dr. Lu.
Professor Lu, can you unmute yourself?
So till Dr. Lu comes online, we can have a short discussion on any of the previous cases that have been presented. So Dr. Qiang or Dr. Qiang Jie, if you would like to comment as co-moderators on any of the previous cases, we have had 3 cases presented so far. One on the proximal tibia growth arrest by Dr. Saleh. Jie Wen has presented on the ankle varus after a very difficult McFarlane fracture. And Sanjeev has presented his excellent case on bilateral blounce. So are there any comments or any thing that you would like to discuss on these 3 cases?
Okay, so I have a question for Dr. Saifi. So what's the indication for the arthrography when you do the measurement of the deformity? So what's the indication for the arthrogram?
This is this question to me, yes?
Yes, sir.
Yeah. Well, I use in that specific case, I actually use arthrogram to place my my 8-plate, because you wouldn't know where exactly you would stop, where you put your wires and where you put your screws. And it also gives you a slight of geography on how the epiphysis looks like. At that time, yes, you can see the destruction on the destruction on the epiphysis, but my target was just to place the 8-plate to see how much of correction we might get with this destructed epiphysis. And eventually, in that specific case, I know that at a certain point, I will have to just kill the whole physis, because it will keep recurring and it will keep repeating the deformity. And then I'll just need to do the deformity correction for that specific segment, and on the top of the distal femur too.
Okay, thank you.
Al, can I ask a follow-up question to Saleh as well? Great case again.
Yeah, absolutely.
I was wondering, with the guided growth, and I know that case from what I recall, he had recurvatum and varus, right? And sometimes we could sort of strategically place a guided growth implant to try to do this sort of biplanar correction. And I guess in this case, if you're using a plate, you would sort of put it more posterolaterally. But I think the technical problem in this case and some other cases is that the fibula gets in the way, right? The proximal fibula gets in the way. So sometimes you cannot put the played that far posterolaterally. And again, I haven't done it that often, but and I'm not a big fan of, PETs or, screw epiphyseal. But I would think that's the one location. If you're trying to get like an implant, a guided growth implant posterolaterally in the proximal tibia, I think this is a good indication to do a screw sort of distal medial to proximal lateral in the proximal tibia. So you could correct the recurvatum and the varus. What's your thoughts on that?
Yeah, you're absolutely right. The 80 blade can be obstructed by the fibula, as you said, and then using a single screw can probably target the two plane deformities. But I think this
Thank you.
is a lot of trouble. Go ahead, Alaric. I think our friend is here.
I see Dr. Qingda Lu has joined us. So do you want to present your case? Jie Wen, if you could project the slides again. Thank you very much.
Hello, can you hear me? I'm so sorry.
Yes, please. Yes, please.
Yes.
Go ahead.
There's some trouble with my computers. Hello, everyone. I'm Qingda Lu from Xi'an Honghui Hospital, and it's my honor to join today's webinar. I will present a complication of angular deformity secondary to Meckel-Albright syndrome. Next, please. This was a 30-year-old female complete with an 11 history, low-grade limb deformities, and worsening guides. Next, please. When she was 2 years old, her limping guide was noticed, but there's no intervention for hers. So 3 years ago, he received acupuncture and rehabilitation at a local hospital, but no improvement. The girl demonstrates precocious puberties. When he's 3 years old, he has the misses until 10 years ago. Next. From the appearance photos and videos demonstrate a girl with wind-swept neck deformities and abnormal walking. Next, please. The X-ray showed the patient with right severe general valgus and torsion, and also combined with scoliosis and the pelvic rotation. Next, please. The three-dimensional CT scan provides a more detailed visualization of the deformities, demonstrate a hip dysplasia, and combine lower limb deformities, including valgus angulation, flexion, construction, and torsional abnormality with the lower limbs. Next. The spine MRIs also show a low spinal tesserae, but with no evidence of neurological deficiencies. Next, please. From the literature, we know that Meckel-Albright syndrome is a rare congenital disorder caused by G protein mutations. The key feature includes caveolate spots, endocrine hyperfunction, and fibrodysplasia, pathological fracture, and
I think he needs to unmute himself again.
Dr. Lu cannot hear you. Dr. Lu, we cannot hear you.
Unfortunately, I think he's having some internet problems. So I think in the interest of time, we need to wind up because we've already exceeded our time. To close the session, I'd ask two moderators, Dr. Qiang Jie and Xin Tang, if they would have any comments or final comments. And then I would leave it to Jie Wen to give us the final feedback slide. So Dr. Qiang Jie or Dr. Xin Tang, if you have any comments about the cases so far, that would be great.
Good afternoon and good morning, good night. I'm Dr. Qiang Jie from Xi'an Honghui Hospital. Now, I have thank you very much to the previous professor to give the very wonderful reports. So the experience they shared demonstrated the significant role of techniques and standard training in the doctor's clinical work. I hope their reports can inspire and assist the pediatric orthopedic doctors from all over the world who are online today. Now let's start this discussion session of today's meeting. Welcome all the professors to continue share their valuable clinical experience. Thank you.
Thank you, Dr. Jie. So I think it's time we close this excellent session because we're running short of time. To summarize, we've had two great talks to begin with by Dr. Sattar Alshryda, who spoke about the understanding of deformity planning, knowing what the normal alignment should be, and therefore how do you do a mechanical axis deviation calculation. And then we had Dr. Chenghe Qin, who spoke about the actual deformity correction and the importance of using the CORA to select where exactly osteotomy should be. We had three great cases, and unfortunately, Dr. Qingda Lu could not complete his case on the vacuole Albright syndrome deformity, because I could see that it was a really wonderful case with a very severe deformity. Would have loved to know what was done for that case, but maybe we can share it at some other point later. So I'd like to thank all of our faculty and panelists for being with us today. I really appreciate the way our conveners have set up the session with a focus mainly on cases with very few didactic talks, and this really makes it very interactive. So Jie Wen, if you can wind up the webinar today with your final slides, that would be great. Thank you so much.
Okay, I think maybe it's more proper to have a conclusion by Professor Zhongli Zhang and Professor Jie Qiang and Professor Alaric Aroojis. Yeah, even give us a conclusion of the webinar.
No, please, Dr. Jie Wen, please show the last slides. Not several slides, I think.
You mean the panelists does the discussion?
No.
No, just share the last slides for the feedback. Yes.
Right.
This one?
So we request, yes. So we request all our members to point their cameras towards this QR code and fill out the post-webinar survey so that SICOT and COEC will send you a personalized certificate of attendance. And the next slide, Jay. We also invite you for our future webinars. The next one coming up is in collaboration with SICOT on Save the Meniscus on the 18th of July. And Sanjeev Sabharwal has already shared with you the IGOT webinar, which is on the 13th of May. And that again would be a wonderful, 13th of June, I'm sorry. And that will be again a wonderful occasion for us to all come together and really discuss in depth using some wonderful cases that Sanjeev has lined up for us. Next slide. We'd also like to take a moment to speak about our SICOT fellowships. You can apply on the CECOT website. There are several universities and hospitals that have opened up fellowships for younger orthopedic surgeons in training to develop their skills through an observership or a formal fellowship. Next slide. And of course, we very warmly welcome all of you to our annual Congress, which is going to be in Madrid, Spain, from the 3rd to the 5th of September. The organizing committee has worked really hard in setting up an excellent academic and social program. So for those of you who haven't registered yet, I would invite all of you to go to the CECOT website and register for this excellent Congress. Next slide. I'll also remind you about the CECOT virtual exams for any of your trainees who would like to take the CECOT virtual exams. These are the dates that have been put up here. And in conclusion, I would like to thank all of you, my co-conveners and the moderators of this webinar for this wonderful collaboration between CECOT and COEC. And maybe some final words from Dr. Zhongli Zhang to wind up this webinar. Thank you.
Thank you, Professor. It's very good honor for us and from COEC, from China. I think we learn a lot from CECOT, and also we hope we can find further opportunity to collaborate and again and to improve the care for our children. Thank you. Thank you.
Thank you, everyone. Have a good weekend.
You too. Thank you.
Have a good weekend.